Thanks, Gaurav. Sorry about this technical hitch. Well, I'm going to talk on phacoemulsification in subluxated cases. And I spoke on the same topic in Hall A, but that was different levels of subluxation. So right now what I'm going to show is advanced subluxation and then what to do. So not where there is no donesis, but here when there is donesis. So there are different situations. So here I'm going to show you the use of femto laser as mentioned by Gaurav. But there are signs that you will get from the anterior capsule that the anterior zonules are weak, and you'll get signs where the posterior zonules are weak. So when you look at zonular anatomy, you have anterior zonules, equatorial zonules, and posterior zonules. So you need to know what is a sign to know that the anterior zonules are weak. So you can see that I've done here CCC, and at this level, the CCC has got stuck at this level. So now I've injected viscoelastic, and now I want you to watch the behavior of the anterior capsule. So look at it, that there is no traction coming from the zonules, and that's the reason why the folds are developing. Again, I'll show you one more case as to how the anterior capsule behaves. Again, look at the anterior capsule, and look at this area where all these folds are. So you can see this area of the folds actually forming during the pull. So there is no counter traction, and that's the answer here, that you will not see donesis, but there is no counter traction coming from the zonules, and that's the reason why the rexis is tricky. So in such cases, you have to be careful. Go ahead and do your phacoemulsification. Once your phacoemulsification is done, you have to do your IA. IA can be coaxial or bimanual. I'll show you a coaxial here. I also do bimanual. But again, be gentle. Don't forget that your anterior zonules are weak. So the traction from the anterior zonules is less, and the bag is going to behave a little differently. Once you've done your IA, all these cases must have an additional support. So here I'm now injecting viscoelastic, making sure that my bag is well inflated, going ahead and then putting my endocapsular ring. So even if your anterior zonules are weak, this patient should be implanted with an endocapsular ring. The technique is very easy. Put in the endocapsular ring, either inject it or place it around, and then use a T or a Sinskey hook through the main incision and just place it into the bag. Coming to subluxation. Okay, so this is subluxation. A young boy, again, there is no donesis. So you can have a 180-degree subluxation and yet have no donesis. Then what to do? So in this case, I went ahead and did a femtorexis. So this was my first case. So you can see the amount of subluxation, you can see the tilt. So this is the OCT that Dr. Gaurav was mentioning about. This is the iris, this is the cornea, this is the lens thickness, and this is the tilt that you see. So this is one of the technologies where you can actually see an axial view and a sagittal view. And you can actually place your rexis away from the area of subluxation. So you can see that here I'm moving the rexis away from the area of subluxation. The subluxation is inferior, and I'm trying to move my rexis towards me, that is superior, away. Now this was my first case, and I did not know properly how to size the rexis. So you can make a mistake here, and I'll show you the mistake I made and how I went about it. So see the size of the rexis? It's very, very small. What is the size it says? 4.9, rather 2.9, and now it's a 3.9. So I did a 3.9 millimeter rexis away from the area of subluxation. Because he was a young boy with a traumatic cataract, I was really not worried. But that is a mistake, and I'll show you another case where I became a little smarter of making the rexis at the right place. So once that is done, I go ahead and do my FEMTO. So you can see a small rexis of 3.9 away from the area of subluxation. Let's see how it behaved clinically. So you can see the small rexis, you can see this area, and this is the area of subluxation. That's inferior, okay? Nothing to worry, soft cataract, young boy, this is all fine. So I'm going ahead, okay, removing the rexis, doing a bimanual IA, and I'm really not worried because there's no donesis. So now I want you to see the behavior of the bag. Look at the posterior capsule, don't look at the anterior capsule throughout the procedure, and see how it behaves. One more take-home message from this presentation will be that the IOL always centers in the center of the bag, irrespective of where you do your rexis. So whatever you do, even if you do your rexis on the visual axis, center of the limbus, whatever you say, now just look at the behavior of the posterior capsule here and the rest of the bag. So when there is traction, the posterior capsule tries to follow the cortex. Can you see that? So inferiorly you can see the posterior capsule. This is the posterior capsule here, okay? And the cortex is trying to be stripped off, and when that happens, but this is fine because the rest of the zonules are very, very strong, really nothing to worry. I go ahead and then put an endocapsular ring. Oops. I go ahead and put an endocapsular ring. That stretches the bag out quite well. And now I put the lens, and when the lens is put inside a decentered rexis, the lens will center in the center of the bag, okay? So this is one more important information. Once that is done, rarely you'll see this in your life, that a femtorexis is manually enlarged. So I'm actually enlarging it to the size of the optic, so you can make it about 5.5 millimeter and make it well centered. So again, my haptic is inferior in the same area of subluxation. I have my endocapsular ring there, which is an additional support, and this does quite well. Another case, you can see the subluxation again here in this area. This is the area of subluxation. This is the femto being done. And this time I'm a little better. So I go ahead and show you how that looks. So you can see a nice round rhexis. You got a 5.5 millimeter rhexis. One more thing I want you to note. The femto fragmentation is beyond the rhexis, even in the area of subluxation. So you are actually pulping the cataract into small pieces, which is otherwise not possible without femto technology. Okay? So here you can see these grooves which are made. This is the area of subluxation. I'm going ahead and then just making my incision, pinch the rhexis out, give support to that area of subluxation with capsular hooks. Okay? So these are capsular hooks which you can see going into position. Once that is done, I go ahead and do my fragmentation. So this case, I'm going ahead and doing phaco. I got my support onto the capsular hook, nothing to worry. Doing my phacoemulsification and then doing IA. Now at one stage, you will notice that the capsular hook actually comes off. Okay? So you can see the capsular hook has come off. Once it has come off, nothing really to worry. You can see the bag. This is a capsular hook which has come off, but the rest of the zonules are very, very strong. So I'm really not worried here. There's really nothing to worry. Form the bag again. You can put the endocapsular ring. Now one trick is if you have to put the endocapsular ring, when the capsular hooks are in place, you have to loosen the capsular hooks because the endocapsular ring will actually move the capsular hooks. So make sure that your capsular hooks are slightly loose, they are not into the fornix of the bag. Then place the endocapsular ring and you will be fine. So I'm just going ahead, giving the support before the IA, and once the endocapsular ring, now you can see that the endocapsular ring is going into place, and go around, loosen the capsular hook and give the support to that area of the subluxation. Another take-home message is make sure that you put the endocapsular ring or start placement of the endocapsular ring in the area opposite to that of the subluxation. Now this is one mistake I made here. This is the area of subluxation and I started placing the endocapsular ring from here. Now what happens is when the endocapsular ring goes into place, your two eyelets come here and here. So the maximum support that is really necessary to the bag is really absent. So this is one more take-home message that if you have subluxation here, technically you should put the endocapsular ring from this side. But being an okay surgeon, what I did is nothing really to worry. I go ahead and rotate the endocapsular ring in the bag. So now what I'm doing, I'm holding the eyelet and I'm dialing the endocapsular ring in the bag to give additional support to the area of subluxation that is here. So that I tried to overcome the mistake I made of placement of the endocapsular ring. So take home message, start placing the endocapsular ring, form the area opposite to that of the subluxation. Once that is done, go ahead and put your lens in the place. This is the last case I'll be showing. A hypermature cataract, more than 180 degree of subluxation. There is really not much choice here. I've done a femtorexis here, but you can see the size of the rhexis. I was damn scared, A, because it was hypermature, and 2, because it was a large area of subluxation. Doesn't matter, I stained it. It's a soft cataract, and I removed that area. Go ahead and make your rhexis little large. Once that is done, the whole subluxation is inferior. So now I'm going to go ahead and put 3 capsular hooks. So sometimes it gets tough, but we can make tough going very, very easy. And that is what you see here, that I've now supported the bag with 3 hooks. Okay? Once I've done that, I'm going ahead and doing phacoemulsification quite easily, going ahead and then doing my IA, and then fill up the bag. And now I have to loosen the capsular hook because I'm going to go ahead and put the CIONNIs, okay? Because my inferior subluxation down completely needs support. So what I've done here is loosened it a bit, then take your CIONNI, okay? Once you've taken your CIONNI, dial it into the bag and make sure that the hook comes anterior to the anterior capsule, okay? To the anterior to the CCC. So now I'm dialing the CIONNI into place. This is where I had made the Skreller-Hoffman pocket. And this is my CIONNI ring going into place. I've loosened the capsular hook and I'm dialing the ring into place. So I'm going ahead and then making sure that I dial the CIONNI into position. Once the CIONNI is in place, so you can see that this and the hook are in a straight line. and the 2 strings will actually come out. Once the 2 strings are out, you just go ahead and do a railroad technique. You can see that I'm going ahead and doing a railroad technique with a 26 gauge needle from one side, the 90 proline from the other side, come out, and then again the other needle coming and get the other needle out, and then you just go ahead and tighten it. So this is a CIONNI in a hypermature cataract, doing a FEMTO, and then a phaco, supporting the bag, and then tightening the suture, and then placing the lens in the bag itself. So the goal here, friends, is the same: to protect the bag, to protect the anterior vitreous phase as much as you can, save it till the last. I think my time is up.
You can have 2 more minutes.
2 more minutes, okay. So this is one more last case I'll show you, a traumatic subluxated case, okay. A trauma is the vitreous has come in the front of the trauma, which you can see a large iris hole there. And now one more trick, that's the last thing I want to show you. If you do CCC and you want to put the endocapsular ring before you do phacoemulsification, put in the viscoelastic just below the anterior capsule. So go below the anterior capsule till the fornix of the lens. Keep injecting viscoelastic, so you're actually pushing the cortex down. This will prevent entrapment of the cortex when you have to do IA, and that will prevent entrapment with the endocapsular ring. So this is one trick and take-home message. I'm putting the endocapsular ring again in position. I'm trying to support there with the capsular hook. Not able to do that, forget that. I'm going ahead and doing phaco, then doing a bimanual IA. Once the bimanual IA is done, again I'm doing IOL placement in the bag. Once the IOL placement, again I'm doing the direction of the placement in the same area of subluxation. Okay, so this is the area of subluxation. Don't forget that the pupil has to be reformed. So here I'm going to do Dr. Amar's technique of 4th row pupilloplasty. I think it's a fantastic technique. I've never done this before, and I found it so easy to do, and immediate implementation. So here I did, and I was practicing, so I thought I'll do one. The pupil looks good, so I got a little tempted. I'll do the second attempt, so the pupil looks even better, and I still had to practice a little more, so I did the 3rd attempt, and the pupil looks even better. So even if you have a subluxated case, you have nice round pupil, vitreous is removed, everything in place, the lens in the bag. So subluxation can really be made easy. Thank you for your attention.